Hi, my name is Cassidy. I did a rehab protocol over a total hip arthroplasty, also called a total hip replacement. This type of surgery is common in older patients generally, but can be performed in younger patients. Causes of a total hip arthroplasty would be if a patient has osteoarthritis, rheumatoid arthritis, osteonecrosis, avascular necrosis, or a displacement fracture that messes up the hip and so they need it replaced. So in this type of surgery, the abductors are typically cut and then reattached, causing weakness in the hip that the surgery occurred on, and so therefore it becomes a big concern in rehabbing to make sure that that strength is recovered. There are 3 techniques for the surgery. There is a posterior approach, anterior approach, a lateral approach, and an anterior-lateral approach. So this here is my patient. She is a 65-year-old female. She fell bending over and pouring out her cat's food and just fell on her hip, broke it to pieces. So her right hip is the surgery hip that we will be looking at today. So the goal of phase 1 is to protect the healing tissue, control any pain and edema that she might be having. Edema is swelling and collection of fluids, pretty gross. To normalize their gait pattern with an assisted device, improve their range of motion, and normalize muscle activation. Phase 1 comprises of weeks 1 to 3 after surgery. Precautions to be aware of at this stage is that we do not go into hip flexion past 90 degrees, so that would be a big no-no. We do not have hip internal rotation because that can cause a dislocation. We do not cross midline, also dislocation cause. And then you also don't want any bending, lifting, twisting, pushing, or pulling. So a good way to remember that is no BLT with 2 pickles, because all of these things can put too much stress on that area, causing issues. And for their weight-bearing status, it will generally be determined by the physician, but most of the time the patient will be weight-bearing as tolerated, which means they can just progress in how much weight they place on the leg, depending on how much pain they're in with it. In order to progress to phase 2, we will be looking for a normalized gait and with the assisted device and minimal pain. So exercises for phase 1 are pretty simple, and they can easily be done in a bed multiple times a day in order to get the range of motion working as much as possible, because the last thing we want is the patient just sitting in bed, deteriorating muscle and not improving. The main goal of these is to enact neuromuscular activation. And so our first exercise will be ankle pumps. So our patient will simply plantar and dorsiflex their feet in order to activate the calves, the gastrocnemius, and then as well as the tibialis anterior. You can do these every 5 to 10 minutes with sets of 10 just throughout the day to keep the blood flow going. The next 3 exercises we have can be performed in sets of 10 about 3 to 4 times a day, once again in bed, so that the patient doesn't have to have a therapist in session with them to continue their rehab. So the first thing we will do is glute sets. So with the glute set, the patient is going to contract their gluteal muscles, and you can usually see their hips raise up off the table slightly. So you will have them flex, hold for a couple seconds, and then relax again. This will be done in a set of 10. Our second set of activation exercises will be quad sets. So the patient will contract their quads. You can usually see the contraction occurring, but if not and they're having trouble, you can tell them to try to press their knee into the table and this will get the correct contraction. Even if there isn't a visible one, just the patient sending the signal to the muscle will help recovery. Our final exercise for this phase is heel slide. So the patient will place their heel on a sheet, or if they have socks on, they could probably just slide it in their bed anyways. And they will simply bend their knees, pulling their foot in, making sure that they don't cross that 90-degree hip flexion barrier, and then slide out. This will help activate the hamstrings and build strength there. All right. So for phase 2, which comprises weeks 3 through 6 after surgery, the goal is for the patient to be independent with activities of daily livings, ambulate independently, and improve passive range of motion. Precautions are pretty much the same as before. We're just getting a little looser on them as we slowly move out of that critical period after surgery. And in order to progress from this, we would like to see a normal gait pattern for household distances, whatever that is in their life, and normalized muscular activation, as well as starting to see some of that single leg stance, making sure that hip is strong. So for the exercises for phase 2, you can continue the exercises from phase 1 and just increase the difficulty, advance them a little bit through modifications, changing surfaces, and increasing resistance. But the ones we are going to work on are, to start, is balance. So my patient is walking with a Trundlenberg gait pattern, in which the abductors of the surgery leg are too weak to stabilize the hip. So as she walks, her contralateral side sways down and her hip goes outward. So that's something you want to watch for in anyone who's had a total hip replacement, because that can be a major sign that there needs to be intensive strengthening of that muscle in order for them to improve. So we will start with balance. If they are okay balancing on their own 2 feet on the ground, you can move them up to a unstable surface, such as a foam pad or a Bocce ball, anything like that. I'm going to have a gait belt on my patient just to ensure that they don't fall or lose their balance, that we got them. She can start by having her hands on the railing to stabilize herself, and then when she's comfortable, she will remove her hands, and we will start the timer. We can do this for about 30 seconds, 2 times each, and then just slowly increase the time. Maybe have a third set of her just standing as long as she can. So the next thing we will do is calf raises. So my patient will step off the foam pad, and she'll step up to the rail, holding on just to maintain balance, and then she'll perform calf raises. This is basically just an advancement of the ankle pumps. It will work those same muscles, and the patient can perform 2 sets of 12 to 15 reps. Finally, for this phase, we will do a 4-way hip motion, which can be performed 3 to 4 times a day and do 10 reps, or once, if they're performing them in a therapy session, it can be 2 sets of 20 reps. So this will work on our generalized hip strength. So first, I'll have my patient do hip extension, and then we'll go into hip flexion, and then we'll go into hip abduction and adduction. In order to not cross midline on the adduction, we're just going to slowly lower it and kind of squeeze at the bottom. All right, our next phase, phase 3, is with weeks 6 through 12. The goal is to regain muscular strength, especially of the gluteal muscles and the abductors, normalize gait, distance, and speed, as if they're walking in a community, like from a store to their car, and then be able to perform their activities of daily living without pain and have single leg standing control. Precautions would be to loosely follow the BLT and other hip precautions at this point, and then avoid multiplanar movements for now. We'll advance to that eventually. In order to progress, we want pain-free hip range of motion in a symmetrical double leg squat and a normalized gait for the community distances. The exercises that we have for this are single leg standing. So basically, the patient will just hold on, be able to stand on one leg, working on that strength. Once they get good at that, you can progress to a foam pad to work on the balance and proprioception. This will be for time up to 1 minute, just to work on that. The next thing we will go to are mini squats. I'll have my patient step off, and then she'll step up, and she will spread her feet hip width apart, and then be sitting back into a chair, right there. And we don't want her to go too far down, just to not go past that 90 right now. So she'll do this for 2 sets of 12 to 15 reps, which engages the quads, hips, glutes, neuromuscular training, and balance training. Finally, we'll go over to the resistance bands. A lovely lady. And here we will perform the 4-way hip strengthening exercises, just a progression of what we did last time, but with a resistance band. So first, she will perform a hip extension, just working on that hamstring and hip control. Then we will go into a flexion, so she will turn around, there we go, and flex her leg forward at the hip. Then we will go into an adduction, so she will start wide and then pull it in, making sure that the resistance is tight enough. And then finally we will go to an abduction, in which she'll turn around and kick her leg out to the side to strengthen all directions of the hip motion. Phase 4 comprises of weeks 12 through 20, and the goal is to increase volume, intensity, begin to work on multiplanar and multi-directional movements, initiate any plyometrics, and in order to get them back to the desired level of function, as well as optimize neuromuscular and balance training. Precautions would be to ensure the patient has proper form of all of these exercises before moving into a higher quantity, and maintain their flexibility and range of motion, because that will play a part in how much they're able to progress, as well as monitor closely any sport-specific movements that they begin to do, watching for that proper form. So we are going to do 3 exercises again. We're going to go over to the Bosu ball. And this is just going to work on the proprioception training once again. You can vary the surface just on the difficulty, depending on how much you think they can progress and how the patient is doing. They will stand there for time, up to 2 minutes. As they get comfortable and confident in that, you can add perturbations, in which you push gently on the patient to change the environment that they're in, and they have to adjust quickly to the change. All right, and so the next thing we'll go to is the leg press machine, which will work on quad and glute strength. So the patient will put her feet shoulder width apart and press through her heels to straighten that. We want to make sure her knees stay in line with her ankles and hips. And we will do 2 sets. Two sets of 12 to 15 reps for this exercise. We will then move into a hip adduction and abduction machine, which will place the patient in resistance for both directions. Once again, just increasing the strength in that hip, and we will do 2 sets of 12 to 15 reps. Finally, for most physicians don't recommend patients returning to high-impact sports just because it places a lot of stress on there. So a lot of times they suggest low-impact sports such as golfing, walking, and swimming. But there are some research articles that show that jogging may not be as detrimental as once thought to be, especially with the improvements in the replacements that we have. So that can take place just under careful watch and physician's consent. In order to return to play and get into plyometric training, you want to make sure that the patient's leg strength compared bilaterally is within 10%. So if this one's at 100% of maximal strength, you want to make sure this one is about 90% of that strength. And you want to do that with the hip, quad, and hamstring muscles. You really want to watch for any gait asymmetry, because if there's gait asymmetry walking, it will carry over into running, jumping, all sport activities, which can increase likelihood for further injuries. And then you also want to make sure they demonstrate adequate sport-specific functional movement. Thank you for coming to my TED Talk.